Hello, this is Dr. Bhaumik. Welcome to my pediatric endocrine and metabolic lecture series. And today I'm going to discuss about a condition which is rather rare in a pediatric age group, even in adult, but more so in pediatric age group. But for completion of the lecture series, I have decided to discuss Cushing syndrome, also in pediatrics. I, however, have modified the lecture in such a way so it will be more helpful to get the salient point and the point that you might need to do very well in your board examination or USMLE. With this background, let's keep on moving. So the outline of the lecture is going to be, first of all, we discuss about etiology, then pathophysiology and incident of Cushing syndrome in pediatrics. Then we are going to talk about the Cushing difference between Cushing disease and Cushing syndrome and historical perspective. As I always share with you that history is a very important subject to me, and especially the medical history of any given disease, and I will just share a little bit with you the historical perspective. Then we talk about the predominant sign symptoms, not there is a whole bizarre symptomatology that one can see, but I will just mention the one that is the clincher to make the diagnosis on clinical basis. Then I'm going to have a diagnostic evaluation and the treatment option and prognosis. But I'm not going to spend very much time on these two because this is a highly specialized subject, and therefore I will just mention for the sake of completion. So what is the etiology and pathophysiology? The Cushing syndrome is caused by excessive production of cortisol and occasionally androgen. So androgen production has much lower incident, but it is the cortisol, and that's what you need to remember. Both children and adults are affected, but it is rare, both in adult but very rare in children. And the source of cortisol could be endogenous, that means coming from inside, produced by the adrenal gland, adrenal cortex, or exogenous. That means the person is getting the medicine in the form of a steroid from outside. An exogenous one is definitely most common in pediatrics. But before we go to details, let's review the physiology of hypothalamic pituitary adrenal axis. This is a time-honored diagram, but let's go through that quickly. At the base of the brain is our hypothalamus, and which produces a hormone or factor called corticotropin releasing factor. This one directly goes to the anterior pituitary and produce or help in synthesis of ACTH, adrenocorticotropic hormone. And then ACTH works on adrenal cortex and produce the cortisol, the main hormone that we are going to discuss today. Cortisol is the most important hormone for everybody because it is the stress hormone, and deficiency of this hormone result in a lot of difficult situation, and that I am going to explain a little bit later. It is a stress hormone together with epinephrine, and cortisol is a stress hormone. Whether the stress is medical or psychological, cortisol is very important. And cortisol also regulates its own secretion in health. And how that is done? It has both positive and negative feedback. Positive means when the body needs more cortisol, it gives a positive impulse and positive information to the hypothalamus as well as the pituitary gland and gets more cortisol secreted in the blood. But when we don't need any or less, then there goes the negative feedback, and we have shown here is the negative path, but it has a positive also come the other direction. So this negative one usually uh, stop production of CRF and ACTH at the level of the pituitary. So this is a diagram which is time honored and is really makes the thing explanation of the thing very easy. So let's go to the historical perspective. Dr. Harvey Cushing in 1912 reported the first case of Cushing disease, or what we call people call kind of interchange in syndrome and disease, and that condition was caused by a pituitary adenoma which was producing excessive ACTH. So that is Cushing disease. When the cortisol is being produced in response to the ACTH, and that's coming from the anterior pituitary gland, and that's your Cushing disease. But the other, which also make the body make more cortisol, but it's not pituitary ACTH, but the ACTH could be ectopic, and that's what we call, altogether we call them Cushing syndrome. So that includes then Cushing disease and any other cause of hypercortisolism. It could be iatrogenic, it could be hyperplasia, it could be cancer, ectopic ACTH. It could be any of those. And the youngest reported case was two siblings. Those were presented their diagnosis within a week, 2 weeks after birth in 1982. And there was also a case report of 4 months old with Cushing syndrome, and that was due to the adrenal cancer. And in adult, the most common disease, common onset of the disease occurs between 20 to 50 years. Let's look at the incident of Cushing syndrome in pediatrics. It's about 2 to 5 new cases per million per year in children. But about 10% of all Cushing syndrome or disease that has been described is 10% is about 10% is children. Clearly, their female preponderance is well known and seen in adult, but that pattern has not been very applicable in pediatric age group. So in some series, there has been some question about probably female preponderance, but the other series has shown that it's the male. So there is no clear-cut preponderance. The most common cause is prolonged exposure to the glucocorticoid from outside, and this is usually given in the form of medication when the patient is treated for, say, bad nephrotic syndrome or very bad asthma and other autoimmune disease. So prolonged exposure will give the cushingoid features. And that's actually more common in a pediatric age group. An adrenal tumor or acetase secreting tumor are most common underlying cause in pediatrics, and 70% of the unilateral, and this is kind of interesting to note that 70% of the unilateral adrenal tumors in young children, especially the below the age of 6, are often malignant. There are some rare causes of Cushing syndrome in pediatrics, and ectopic acetase tumors are very rare in pediatrics. But bilateral micronodular hyperplasia involving the both adrenal gland, usually seen with a condition called Carney complex. Very rare, but this is usually in the younger age group, around the age of 2 or 3, and it could be in combination with the Carney complex. In children over 6 years of age, however, most common cause of Cushing syndrome is acetase secreting pituitary adenoma. And I just want to emphasize again that when the acetase come from the adrenal gland, and that's Cushing disease. So acetase secreting pituitary adenoma is most common after the age of 6. And then we all know about that syndrome called McCune-Albright syndrome, which is associated with precocious puberty and also may have a problem with adrenal tumor, Cushingoid syndrome. At the same time, they also might produce hypothyroidism and growth hormone excess. Now, I'm going to emphasize on some of the clinical findings. And to me, that's very important to note. And that's this part is mostly clinical discussion. And this is the one that medical student, resident, those who are taking the exam will be very helpful to know. Now, weight gain is the first thing that one see. The weight gain is very common around the face, abdomen, and at the same time there is a thinning of the arm and leg. So they call tapering of the extremities. However, that features is described more commonly in adult. In children, one condition that is, one finding is almost always seen is the weight gain and the moon face, round face. Weight gain, and that's very much around the face, and it could be generalized obesity instead of just being abdominal obesity. But the key point is that growth retardation. So they not only gain weight, but they stop growing, which is very classical. and there is high, they may have a borderline or high blood pressure, muscle weakness, and the purple stress mark can be seen around neck, over the abdomen, and patient is usually very irritable. Very irritable patient, the appetite is not that great that one would like to see in exogenous obesity. And the other thing, one have to look, and if they find hirsutism and in adolescent irregular period, acne, and male pattern of baldness, that will suggest that there is androgen excess as well. This is the little picture that I was talking about from the Cushing syndrome library, and you can see this is the little baby who is less than 6 months, and you can see the round face, but the abdomen and other places are really not that remarkable, but the face is obesity of the face, or the round moon face, what we call. I want to draw your attention to this diagram, to this growth chart. This is a growth chart B. B I am going to discuss first. You can see that this is exogenous obesity because of too much consumption of calorie. And here you can see the growth, weight gain has started and going up and up. However, as far as the height is concerned, height chart, really no changes. They are exactly following in the upper percentile, but they have not shown any deviation. And this is very classical of your exogenous obesity. And actually the obese children, usually their height is in the upper percentile also. As if you can recollect in my obesity lecture, this about 70% of exogenous obese children, after the age of 7, they are above 70th percentile in terms of height, and obviously above 90th percentile, and so forth for weight. So this is a classical exogenous obesity. Now let's go to the chart A. You can see the child was up to here is all right, and then slowly and gradually weight has started going up and cross the line. But look, interestingly, the height has been falling. This patient is losing ground in terms of height. So this is very classically seen in Cushing syndrome, or actually other endocrine cause will be, the most common one will be hypothyroidism. Severe hypothyroidism in the younger age will have retardation of the height, but weight gain, and growth hormone to some extent also might do that. So this chart is very important, and do please remember, this will help you in your exam. And again, this is a 10 years old boy chart with growth Cushing syndrome, and said the same thing. The height has started falling from the percentile and the weight is going up. This is the picture that again is from the library of Cushing syndrome. So there is no need of getting any permission. The royalty has expired. So this is a kid with 2 years old with Cushing syndrome. As you can see, there is a moon face and there is abdominal obesity some, but not much in the extremities. And this is another same person, it's just like as in the back, as you can see, there's a little bit of lump, and this could be called as what classically we used to call buffalo hump, and there is some degree of hypertrichosis. Now, does not look like androgen dependent here, but sometimes this pattern of hair also may be the early sign of androgen excess. So, confronted with a condition that where you think that the patient may have Cushing syndrome, the first one has to prove hypercortisolism. And the time-honored AM/PM cortisol is also first thing that we do. As you know, AM cortisol level is higher than PM. So that blood test will be helpful. And nowadays, people are doing the midnight salivary cortisol. We do the serum ACTH to determine what is the level of the ACTH. And if there is any cessation of androgen excess, then the best test to do is dehydroepiandrosterone sulfate, because 90% of this hormone come from adrenal gland. So this will be something that you would like to do. If you see any evidence of hyperandrogenemia. However, this is very important. 24 hours urinary-free cortisol. In some institutions, they collect up to 3 24 hours urinary-free cortisol. But the things are advancing, things are changing, and all the cortisol and all other tests actually will be coordinated with a pediatric endocrinologist or adult endocrinologist. So anyway, I think the job of the primary care physician is to identify this condition and refer, and so that timely investigation is done and the treatment is taken care of. Then again, dexamethasone suppression test. People know about that. Takes to see that whether this will be of any help. If you show the blood sugar, blood glucose, it may be upper normal or clearly high. Free T4 and TSH ought to be done. As I have mentioned to you that hypothyroidism will present very similar pattern of growth chart and also obesity. Then X-ray, sonogram, CT, adrenal MRI, pituitary MRI, that all will be decided by depending upon the etiology you are suspecting, and clearly these tests will be done by the specialist. In adult, the bilateral petrosal sinus sampling is, as they say, the gold standard to rule out ectopic ACTH versus pituitary ACTH. And so that's very, very, very rare in pediatrics, not that I know one, but again, adult, the cause is known and it is done in institution where they take care of this kind of problem. Treatment and follow-up is, again, I'm not going to spend much time because it is will be followed by endocrinologist and the surgery depending upon what kind of problem. However, endocrine follow-up is going to be lifelong because of the surgery or whatever is the cause. Other hormone deficiency may occur, so they might need some extra hormone for future, and so endocrine follow-up probably going to be for lifetime. So thank you very much, and I know that this is not a very common condition, but it does exist, and I know that I'm trying to cover the area which will be more important to our audience, medical student, pediatrician, fellows, or so forth. And if you think anybody can be helped or they want to know that they can just refer to my link. Just type it in Google or YouTube search. And so far I have submitted 34 topics all on pediatric endocrine and metabolic subject, and there had been more than 100 board question, pediatric board question related to endocrine and metabolic section. My next lecture will be Addison's disease. Thank you again.